Good evening, everybody. Can everybody hear me all right? Yeah. So for those of you that don't know me, my name is Darren Baulch and I'm a orthopedic practitioner based at the Royal Glamorgan Hospital. I've worked for the NHS for over 20 years. 17 years of those in the emergency department at the Royal Glen Hospital. And since 2018, I've been very fortunate to work alongside some great orthopedic practitioners at Bristol Royal Infirmary, Bristol Children's Hospital, Prince Charles Hospital, and of course, where I am based now at the Royal Glamorgan Hospital. So, tonight's session is about casting tips. What I don't want to do is just, I appreciate the fact that lots of people already have great experience of plastering, so I don't want to come in and tell you this is how you have to do it. All I'm trying to do is give you tips on how to make it maybe just a little bit better for yourself. So, the aim of the webinar is not to teach people how to suck eggs. So of course, like I said, I can appreciate you've all done it significantly, a lot of you have done it significantly longer than I have. But it's about getting the basic principles of emergency casting right the first time. This will lead to a better outcome and of course, patient satisfaction. Now, the tips I will show you today have been successful to me. They've reduced pressure areas. They've reduced the needs for further manipulations or surgeries where reductions have been done, if they're done right. And of course, with this, they've reduced the need for litigation claims as well. So I'm going to break the session down into two sessions, although there won't really be a break in the middle of it. So the first part of the session is we're going to concentrate on upper limb casting. So we're going to look at below elbow back slabs. We're going to look at below elbow back slab with collie reductions. We're going to do roller slab in Edinburgh position. I'm going to do a Bennett back slab, thumb spiker, and I'll show you how to do an above elbow back slab. When I do the above elbow back slab, I'll also show you how to do it for the Barton-Smith fractures. And then I'll concentrate then on the lower limb then when I will look at Baloney back slabs and the Vte assessments as well. So, excuse me. So we look at first things first. So the first things first is triage. Anybody comes into hospital, the first thing that they're going to see is the triage nurse. And the triage nurse is going to assess that patient. So fractures are classified in different ways. So they can often be described in terms of what we find when we examine the patient. And this is known as a clinical classification. So with regards to the clinical classification, if your patient comes in and they've obviously got the deformity, the swelling, the pain, then your clinical classification is you identify a fracture. You send the patient to x-ray, and then of course, once they've had the x-ray done, then your fractures are classified then by x-ray classification. So if a patient comes into the triage and they've got symptoms of a fracture, so we look at the mechanism of injury, the pain, we look at swelling, the deformity, you could have a loss of function, you could have an abnormal mobility, and you can have crepitus. So if the patient was to attend the triage and come up with any of these symptoms, then of course, the first thing you need to do is ensure that you've got adequate pain control. And of course, you need to make sure the jewelry is removed. This is one of the biggest bugbears for lots of people within plaster rooms, is patients coming around for their plasters and they're still coming around with the rings on. So it's about stressing the importance of making sure that you get the assessment right first time. So what is a below elbow back slab? So a below elbow back slab is exactly what it says in the tin. It's a slab of plaster that covers the back of the hand and it works as creating a splint to immobilize any fracture. Of course, with this, it's almost like having a future splint on, but having the inability to take it off. So when we apply a below elbow back slab, there are a few things we have to do first. So the first things first, you have to confirm the patient with the limb. And of course, you have to confirm this with the prescription and the x-ray. I have seen an instance where someone has had a injury to one side of the limb, has guarded the limb and made out the fractures on the other side, and then was casted on the wrong side. So once you've confirmed your details, you need to ensure that you've got consent. But before you gain the consent, you need to let the patient know what it is that you're about to do. If you're about to give someone a plaster, of course, putting a plaster on any patient comes with risks. So the risks are you can end up with stiffness. We're going to look at pressure areas. Your patient can have allergies or a circulatory impairment. So once you've explained these risks to the patient, only then, once the patient understands the risks and what you plan to do, can you then effectively gain the consent to treat the patient. You then need to check the patient's limb. So you were looking at radial pulses, you can look at cap refill, any loss of sensation, you can look at the range of movements. And then, so of course, by checking there's no neurovascular deficit, you need to make sure there's no wounds. So any wounds that put on there, of course, that would be dependent on how you dress your wounds, will be dependent on your local policies and your departmental guidelines. However, once that's done and you're prepared to put your plaster on, again, ensuring that there are no jewelry on. If the patient comes to the plaster room and they have jewelry on, it's important that it's taken off as soon as possible. So I'm going to show you a couple of photos now of preparation for a below elbow back slab. So you have to bear with me a second because I'm not very good with the technical side of this. Sorry, I'm having a bit of a technical issue getting the photos up a second.
You all right there, Darren? You know.
Yes, yes, not picking it up at the moment.
Okay. Oh, there we go. We got something.
Oh, I got it. I got it. Can everybody see that? Okay.
Not yet. It's just coming in.
Has that not come up?
There's nothing there yet. It's a blank screen.
Right. Let me stop that share a second. I'm going to try and go into screen sharing again. So I'll just see if that works a second.
Okay.
Screen. This worked perfectly well 10 minutes ago. Right, let me try that again. Sorry about this, guys.
Slow.
Okay. So that's telling me it's gone across, but it's telling me it's not connected to the Zoom user.
On the screen, all I can see is that you've started sharing the screen and double click to enter full screen mode.
All right, let's try this again.
What sort of file is it, Darren?
Sorry?
What sort of file is it?
Right. I'm just going to try this. I will try this one last time. I literally tried this 20 minutes ago with John just to make sure it all worked and it all worked fine. So I'm just going to try this one last time. Oh, there we go. Can you see it?
Yeah.
Lovely. That's right. Sorry about that. So here's the equipment that I use when it comes to applying a below elbow back slab on. So I'll go through the layers first of the plaster. So when you look at my below elbow back slab, at the distal end where I've cut around where the thumb would be, you can see there's a well-lined edge to it. So it's a rounded edge, so there are no sharp edges on there. So the way I do this is by taking 5 layers out of the box. So say for example, your patient's limb is 26 centimeters long. You pull out the 5 layers of slab from your box, you fold the slab over and then pull out again. So you've got 10 layers and then cut. This is guaranteeing, so this is a great tip for me, the guaranteeing that the edge of your plaster is smooth. And can everybody see me as well as the video, the picture?
Yes.
Yes, lovely. Right, so I'm going to show you why. If you use 5 layers, you can end up with a sharp edge like this. Can you see that? Everybody see that okay?
Yeah.
Yeah. Whereas when I use the 8 layers and fold it over, I end up with a rounded edge. So by doing this, I actually reduce the chances of developing pressure areas. So of course, I'm going to give a quick demonstration now. So use the rounded edge in my balloon. No sharp edges. And then this one. Ooh. It's sharp. So this is why, so when I look at doing below elbow back slabs, whether it be for adults or peds, I always make sure I'm using an even number. So by using an even number, I'm folding the edges over. So the way I do it is once I pull up the slab from the box and I folded that over and created 10 layers, I pull out the 1 from all the way around and it's left me with my 8 layers with an evenly smoothed edge around the sides. I got my, with that piece I've taken off, I cut off my little slab to seal the bandage, and I got my 7.5 centimeter bandage, I got my 7.5 centimeter wool, I got my scissors, and most importantly, my written advice. So what I'm going to do is, I've shown you the equipment that I use. I'm going to do step by step as to how the back slab is applied, and then I'm going to do a video then. So I'm going to show you the video of the slab being applied. Is that okay? Everybody okay?
Sounds good.
Okay. So this is the first photo. So the wool, we will start wrapping the wool up at the elbow part. So at the proximal end. So when we apply the back slab, we want to ensure that the back slab goes high enough to allow for flexion extension in the elbows, far enough to the metacarpal edge to allow full flexion extension of your fingers. However, when you apply the wool can go right up in the antecubital fossa, and the wool distally then can go beyond the fingers, so you can fold it back and access the fingers once you finish applying your slab. So I've gone 50-50 up with the wool, and then come down just out once more on the wrist end, just to protect any bony prominences, especially the ulnar styloid. But if you do have a bony ulnar styloid, again, not be afraid of using adhesive felt wool if you have it. This is the picture where the slab has been applied. So with the slab over, you can see that it's high enough to allow for flexion extension of the elbow. It's far enough to allow for flexion extension of the fingers. But there's plenty of wool at either end, the proximal and distal end, to be able to fold it over and protect the edges of the cast as well. So you can see now that with the edges of the wool folded over, you can see it's up high enough at the knuckles to allow for flexion extension of the fingers, and should allow for a great range of movement within the elbow. Once that's done, I use my bandage, I roll the bandage on, and then I use that little off-cut of plaster and just to seal the end of it. Now, there's been huge debate as to whether or not it's appropriate to use wet bandage or dry bandage. Apparently, it's been proven that using wet bandage, as the bandage dries out, it causes constriction. So it contracts as it shrinks back to its normal size. Some see this as a good thing, some see it as a bad thing. Now, the reason I see it as a good thing is more often than not, when your patient comes in with these injuries and you apply your back slab on, they're going to have swelling. And of course, if they've got swelling, you want to make sure that this back slab accommodates that swelling. So of course, the best way to do that is I have a wet bandage. And of course, the wet bandage on the plaster means that by keeping the plaster a little bit wet, if you want to do a collage reduction, the wet bandage will give you a bit more play with your plaster. And of course, the last important thing for me with regards to applying my back slabs is cleaning the limb. The importance of cleaning the limb is huge from a plastering point of view. If you leave dry plaster around the proximal or distal ends on the thumb or the hand, those dry bits of plaster can't fall off into the plaster. And of course, it's like having sandpaper against your skin. It can create significant amounts of pressure areas and cause harm for the patients. So it's important that while the plaster is still wet on the limb, get it cleaned off before you finish. And this is how it looks like at the volar side. So you can see it comes up to the palmar crease. So of course our palmar crease is allowing then the full flexion and extension of your fingers. So I'm going to show you a video now of me applying the below elbow back slab. And I'll talk through it as well. So I want to make sure the patient is comfortable. Make sure we're clean. And of course, when it comes to applying the wool, we start from the inside out. The reason we do this, if you do it from the outside in, by the time you come to the hand, you're going to end up crushing the fingers. So it's important we do it inside out. So I got 50-50 coverage. And I'm ripping the wool around the thumb. What I see a lot of is holes being torn into the wool and the thumb being put in. And then, of course, when they get swelling, of course, that creates a tourniquet effect around the thumb. And then I finish off then at the ulnar styloid, making sure there's a little bit of wool there to prevent any pressure areas. So when it comes to applying the slab, you want to make sure the slab is wet. Don't squeeze the water out of it. The wetter, the better. Of course, by doing this, it allows you a bit more time to play with it, and it gives you a better chance of conforming it to the limb before it dries out. And then when it comes to applying it and smoothing the plaster, we start from the middle and using our thumbs on our hands to sort of get the bubbles out of it. So we got one whole wet laminated piece of plaster. So make sure there's nothing rubbing the thumb. And then I want to protect the skin. So of course, by protecting the skin, what I'm doing is actually folding the wool. Despite me using 8 layers and rounding it off, I still want to do what I can to reduce pressure areas. So these videos are actually showing a much slower rate than what they were recorded. So it's a bit beneficial for me because I get to go talk through it as well. So then I use my wet bandage. So the wet bandage will be applied the same as the wool from the inside out. Now we don't apply a great deal of tension to the bandage, but we want to make sure that we've got a good, decent coverage. So I'm going around, I'm locking the bandage in. And of course, you can see here, I'm actually cutting the bandage again. So what, again, the same applies to the bandage. We are seeing lots of holes being cut into the bandage and then fed over the thumb. When the thumb swells, when they come back to trauma clinic, of course, that makes it difficult for us because we have to find a way of accessing that. And this is where they're more likely to develop the pressure areas if it's a tourniquet is dug in when they get lots of swelling. So I've gone up the arm. I've gone 3 times around the web space. Cutting the bandage every time. And I'm only gently applying a small amount of tension to the bandage, not a great deal. Now, while there might still be bandage left on, it doesn't necessarily mean that because there's bandage there, you've got to use it all. Cut it away, you don't need it. If you don't need it, get rid of it. And then what I've done here is I hold the end of the bandage, and then I use the last of the plaster that I cut off from that 10 piece just to secure the end of it. Now, the reason I don't use tape on this is that if I was to use tape, of course, the bandage would be wet, so there'd be nothing that would stick to it. And of course, the slab then is put away from the fracture site. Although they can still see a fracture on an x-ray if they have a post-cast x-ray, the slab of plaster, depending on how much you use, can create artifact on the x-ray. And the leftover wool, this is what I use then to clean the fingers. So I clean the proximal and distal ends. So you want to make sure that none of this falls into the plaster. Again, we don't want to have that sandpaper effect inside the plaster. And I'm just going to check. So with most plasters, every time we apply the plaster on, we make sure there's no neurovascular deficit. We ensure that the patient got all range of movements of their fingers, thumb, and the elbow. So that is how I would apply my below elbow back slab. So we also look at applying below elbow back slab for Colles reductions. Now, so the Colles reduction was first identified by an Irish surgeon, a gentleman by the name of Abraham Colles, who first described it in 1814. Now, Abraham Colles, he identified the fracture just by looking at the deformity. So he did exactly the same as you would do in triage, your clinical classification. And of course, the reason he only had to use clinical classification is because at the time there was no x-ray. In fact, x-ray wasn't invented until 1895. So that works out 81 years after Abraham Colles identified this type of injury. So what is a Colles fracture? So the Colles type fracture is a result of a fouche, so a fall on an outstretched hand, and it will often present a triage with a dinner fork deformity. Of course, the x-rays then will show that they have a fractured distal radius within 2.5 centimeters of the articulating surface. There would be posterior displacement and dorsal angulation. And of course, with the true Colles, they will end up with an ulnar styloid fracture as well. So there are two types of Colles that the term that they use. So with the Colles type fracture is often the fracture of the distal radius with posterior displacement and dorsal angulation, but it doesn't involve the ulnar styloid. It's only involvement of the ulnar styloid that they consider a true Colles fracture. So what I'm going to show you now is the plaster. So I'm going to show you another video of a back slab being applied, and then I'm going to show you two videos of both of the pre-plasters being used during a Colles reduction. So with the Colles reduction videos, I'll explain to you now, they are obviously broken down and made much quicker, shorter, and they are actually students, not an actual patient. So I'll try and get these videos up now again for you. That should come up. There we go. So this is another method I use for applying a below elbow back slab. So again, the same principles would apply as you would do with your back slab, but I want to make sure that if you need volar and dorsal molding, then this is a technique that I use to ensure appropriate molding at both at the volar and dorsal aspect. So I'm using 15 centimeter slab with a hole cut for the thumb. I want to make sure that hole is big enough so again, it doesn't create a tourniquet effect on the thumb. I'm using 7.5 centimeter wool, a 7.5 centimeter bandage, and of course then the slab and my written advice at the end of the plaster. So I'm going to show you the video of me applying this cast, and then I'll show it now being used then for a Colles reduction. So again, so the same method is being used with regards to the application of the wool with this one as it was with the first back slab. So there's 50-50 wool all the way up. Again, going beyond the metacarpal heads because I want to ensure I've got enough to fold back and I'm not cutting for the thumb. And I'm tailing the wool off edge just at the ulnar styloid to reduce any pressure areas. So again, you want to make sure the plaster is nice and wet, so you've got plenty of room to play with it. And once over the thumb, you need to obviously squeeze the bubbles out. You want to make sure all that one layer of plaster is laminated. And again, then folding the wool over to make sure that the plaster isn't directly onto the skin. I do work with some colleagues who prefer to use dry bandage, but unfortunately I'm old school, and I think I've been taught to use wet bandage and it's worked effectively for me, and I've had no concerns from it. Again, cutting the bandage, making sure that we're not cutting holes into the bandage because we don't want the thumb caught up in a hole in a bandage if you've got a swollen thumb. So I've gone through the web space 3 times, and then I'm going to make my way back down the limb. And of course, with this, I want to secure it away from the fracture site again. So using the offcut of the plaster again, then just to ensure then that this is stuck well and it doesn't come off. So using my leftover wool again. With cleanup. Videos paused. So it looks like that video stopped there. So I'll take that video away now. We finish with that. So we're going to show you now the 2 videos of 2 college reductions being done, but both using the types of plasters that I've shown on here. Can everybody hear me all right?
Yes, you're coming across.
Yes, thank you.
Thank you.
Yeah, you're doing great.
Yes, thank you.
Okay. So the sequence has been shortened. So we want to ensure that when you do the counter traction, the elbow would ideally be at 90 degrees, because if the arm is extended, you're effectively pulling from the shoulder and you're not going to get a very good reduction. So again, I've gone round the web space once. I've come round to protect the ulnar stylo with the padding. And I've concertinaed my plaster. So fold it in together so I can grab it quickly to apply this back slab. So again, when we apply the collie cast, it has to be quick. but at the same time, you need to make sure you get the plaster on right as well. So what I've done is where I would normally fold back the proximal and distal ends of the wool, I'm only folding the one end at the moment. So what I'll do is I'll use one bandage just to get the plaster in place. And then we'll worry about the aesthetics. So what I use here, the technique I use is the knee. So the reason I'm a big believer of using the knee is that once the college reduction has been done, there's no reason why it should be continuously manipulated when the plaster goes on. If the plaster goes on and is continuously manipulated, what you find happens is the plaster gets pulled down the hand, you restrict the ability to move the fingers, and of course, increasing the chances of stiffness and pressure areas. So this is the technique that I use. So the elbow gets dropped. Just going to stop that a second. So the elbow gets dropped and the wrist gets dropped. And then I use my hand. So then once the palmar flexion is being done and the elbow deviate, my hand stops that from being pulled anymore. So it comes down. By using the knee in the hand, it reduces indentation of fingerprints in the cast. So when we look at pressure areas, Blackpool Teaching Hospital did some research on some litigation claims from plaster application and plaster removal. And it started in 1995 and finished in 2010. So there was 15 cases, 15 years, but there were 43 cases. Now, when we look at the 43 cases of pressure areas, we can often say, that's not too bad, 43 cases in 15 years. However, what it cost was £2.3 million over the 15 years. £2.3 million over the 15 years equates to £150,000 a year. And every patient who had a pressure area from the plaster was entitled to a £48,500 claim. So of course, it's a significant amount of money. So if we had to break that down to £150,000 a year, that's 6 registered nurses a year that we could have paid for. I say we, of course, we mentioned the NHS. So I'm going to show you another video now, and it's again, the collies reduction being done, but it's using the second cast that I applied. So the one with a hole in the thumb. Right, let's try that again. So hopefully that'll say. So again, the sequence has been shortened because this isn't so much about the college reduction. This is about the plaster being applied. So again, we've got the even 50-50 coverage, and then once around then just to protect the ulnar styloid. So you can see the cutting for the thumb is wide enough to make sure it doesn't cause any constriction on the thumb. And then I want to quickly get one layer of bandage on. Now, the idea being with this is that it gives them plenty of time to get their reduction, their molding done. Sorry, not the reduction. The reduction should have been completed by this time. So again, I would use the knee. And the elbow gets taken down. And then with the traction in the hand, they can ensure then a good palmar flexion with an ulnar deviation without creating too much palmar flexion. What we don't want to see is this. So by putting the knee there, it actually prevents people from actually grabbing your cast. Okay. So what is a good collision reduction? So we want to make sure that you try and align the bones the best that you can, but we want to ensure that we maintain function of the limb as well when the cast comes off. So we look at ensuring that the position is correct. We're making sure that it doesn't go too far beyond the metacarpal heads and too high up enough to restrict the movements of the elbow. It's very difficult for me to see everybody at the moment. I can't see, but when you look at doing your collision reductions in ED, does anybody know when that cast gets changed? I can take numbers, I don't mind. Or nobody, can anybody speak? Or
we can all come off mute and give comments or put them in the chat bar.
so what I'm just going to ask you a couple of questions, Julie, if that's all, just to make sure that everybody can, I just want to get some answers from people, that's all.
Yeah, sure.
So in our organisation, it doesn't get changed per se, it gets added to. So
That's
they
right.
come in fracture clinic.
That's right. So what a lot of departments tend to do is they preserve, I mean, we know as shop workers, people who work on the shop floor, that often that is the case, that, you know, people will come into A&E, they'll have a collision reduction done, and we, you know, for lots of people, they end that perception that when they go back to fracture clinic in a couple of days, this plaster, how big or bulky it is going to be taken off and they're going to be put into another cast, a lightweight cast. But like you said, Emma, you're right. This is why it's important that we get it right now when you do the collision reduction, making sure that it doesn't go too far beyond the metacarpal heads. Ensure that it doesn't go too high up. Because when they do come back to fracture clinic and there's a good reduction, these casts do not get changed. Like you said, we then complete the cast. So we reinforce it with a synthetic material. By doing this, we can maintain the position and of course then reduce any further complications by changing the plaster at a risk of creating slip of the plaster. So of course, this is why we try and educate people to make sure that every time they know they're having a reduction done, you know, for a lot of people, if I don't know where everybody works, but if you work in an area where you have orthopedic practitioners covering the site, then it makes it easier because often enough the advice is given by the orthopedic practitioners and they educate the patient and of course reassure the patient to say that, you know, they got a good plaster on, and if the molding and the reduction is done right, that plaster won't need to be changed. So what I'm going to look at next is the volar slab in the Edinburgh position. So we call it the volar slab in the Edinburgh position, but it's also called a volar slab in the safe position and a volar slab in a position of function. So when we look at these types of casts, the reason we use these are for metacarpal shaft fractures. You can have them for certain metacarpal head fractures, metacarpal neck fractures, and of course metacarpal base fractures. And of course, some doctors also like to use them for finger injuries as well. So why would we use the volar slab in the Edinburgh position? So the reason we use the volar slab in the Edinburgh position is that it would relax the soft tissues on the fracture site. It maintains finger extension. But by doing that, then we reduce stiffness and contractures. So the term I like to use with the volar slab is damage limitation. When you apply your volar slab in the Edinburgh position, you are supporting the fracture site, but looking beyond the plaster. So once the plaster comes off, you'd like to think that if the fingers have been extended, you're going to reduce our chance of developing stiffness. So I can't see everybody on screen, but what I'm going to ask everybody to do is to put their hands in the screen if you can see your screen. So the perfect volar slab in Edinburgh position would be a wrist in 30 degrees of extension. So I'm going to drop the wrist back and turn around, wrist back in 30 degrees. So your metacarpal phalangeal joints then will be in 90 degrees of flexion, which is there, and your IP joints then in full extension. This is your volar slab in the Edinburgh position. So again, we do it like this because we think of damage limitation. So what I'm going to do now is I'm going to show you a little photo, and the photo is my volar slab in the Edinburgh position, and that's all my equipment laid out. This is all I need for my volar slab in the Edinburgh position. And then I'll show you the video then of the cast being applied. Is that all right?
Mm-hmm.
Okay. Now let's try this again. There we go. So it's getting a little bit easier now. So this is all you need for your volar slab in the Edinburgh position. I've got a 15cm slab in 8 layers. I've got my offcut then to support, to anchor the bandage down. I got my 7.5cm wool. I got 3 offcuts of 7.5cm wool. And I got 2 10cm bandages with my scissors, and of course the important written advice to go with the plaster. So now I'm going to show you the video of how I apply my volar slab in Edinburgh position. So of course, this makes it relatively easy at the moment, using it on a model that doesn't have the injury. But these 3 little offcuts I've put between the fingers. And then I'll show you why I've put those between the fingers at the end. So again, ensuring I get a good 50-50 coverage. But this time, as we're incorporating in the fingers in the cast, I want to go beyond the fingers. Again, this is ensuring that I've got enough wool at the end to fold over to protect the cast and protect the patient from developing any pressure areas. So if you've got fifth metacarpal head fractures and you've got angulation, displacement, or internal rotation, they would often need molding. So again, with the molding, if you are going to mold these areas, it's often a good idea to put some adhesive felt padding on the wool where you are going to do the molding. Again, you want to ensure that you reduce your chance of developing pressure areas and any litigation claims. So the plaster has been saturated. And I want to conform the plaster to the limb. So I'm going to squeeze air bubbles out of it. I want one whole laminated piece. And then the same apply. So I want to fold the wool over. But what I always do is I make the plaster beyond the fingers, and I can cut it in line with the fingers end, so I know there's a plate there with the fingers. And the same apply then with the other slabs I've shown you as well. So again, popping the wool over, securing the plaster, and ensuring that I'm reducing the chances of pressure areas or letting the plaster slip in. So again, this then gets secured with a wet bandage. So again, roll it starting from the inside and working my way out. So speed is of the essence when it comes to doing volar slabs in the Edinburgh position, because often enough, when you have these patients with these injuries, you want to make sure that you've got a bit of time to do the molding, because the patient can't hold their hands in these positions. It's only when the cast is on and you do that molding. So again, getting that wrist at 30 degrees of extension, you want the metacarpal phalangeal joints at 90 degrees, and then the interphalangeal joints and full extension. So in an ideal world, I would probably hold this for a little bit longer, but I think for the purpose of the videos, it's just showing how to get the molding done, but it's not a bad position. And then I want to look at the aesthetics. So I want to make sure, again, I'm checking any parts that can create any complications, any rubbing or any pressure areas. So I want to catch the wool in. And by catching the wool in, I'm actually reducing the chances of the wool actually coming back out. Again, protecting the edges of the plaster, again, protecting the patient. So I'll cut off any excess bandage, and again, then I'll use the last bit of the cut off of the plaster just to anchor that down and protect it. And again, then, so just using the last of the wool, any offcuts that you've got, just to clean up the skin and ensure that there's no plaster panish remaining on the skin. So here I'm counting the four fingers. I can see the fingers. So what the wool does is, by applying wool between the fingers, it stops you crushing the fingers together. What you can often see a lot of is, you can often see that when a volar slab in the Edinburgh position is prescribed, you'll often see that the doctor will often prescribe neighbor strapping or buddy strapping. Of course, so the buddy strapping, the idea of the buddy strapping is if you end up with, say, for example, an index finger injury, and you want to prevent someone from developing stiffness, you strap it to the next finger, so the next finger gets that gentle movement going. So it's again about reducing the stiffness and improving the healing process. If somebody requests a neighbor strapping with a volar slab in Edinburgh position, there is literally no need for it because you're already immobilizing those fingers in the cast. It's not going to go anywhere. So the next plaster I'm going to look at is a Bennett's back slab. So I'm going to show you the tools for the job first. Just bear with me, that's not showing up a second. Oh, there we go. There we go. So here we have all I need for my Bennett's back slab. So we use the Bennett's back slab for fractures of the first metacarpal, but I can appreciate that lots of other hospitals will use them for dislocations of the thumb, other soft tissue injuries, soft tissue ligament injuries. But of course, it's called a Bennett's cast after the Bennett's type fracture. So it's a fracture, often fracture dislocation or displacement of the first metacarpal. So here is all I need. So I've got 7.5 centimeter bandage, 7.5 centimeter wool. I've got a slab of the 15 centimeter slab. And so the slab is exactly the same as if I was doing the below elbow back slab. And then I've got an extension here to apply to the thumb and then my offcut. So I'm going to show you the video of this being applied. So again, ensuring the 50-50 coverage. And then cutting the wool to go around the thumb. So with the wool, I'm going to cut the wool twice around the thumb because I want to protect the thumb as much as I can. Of course, it's the thumb that puts us at the top of the evolutionary tree. So I want to make sure I do what I can to make sure we get a good cast on, a good mold. But again, I want to reduce any chances of any pressure, there's any complications. So you can see I've come around twice, round by the theme eminence and the web space. I want to make sure that if this is a typical Bennett's type injury where you need a mold, then of course I want to make sure I've got a little bit of extra wool just to make sure I can accommodate for the molding. So you'll see with all my slabs, so every time I use plaster of Paris, I never wring the water out. I think the wetter it is, it does actually allow you to laminate the plaster a lot better. You don't want to spend a great deal of time laminating this because what you want to do is actually get the thumb part on to attach to the plaster that you've already applied on, and then they will adhere and laminate together. And you can see where the cut is. And the same would apply then with all the other slabs. Folding the wool over, protecting the edges of the plaster, and making sure that I can see that it hasn't gone too high or not high enough. I have to apologize, the video does seem to be playing a little bit slower than I was actually recorded. But hopefully it'll just make it a bit easier for people to take it on if that's the case. So the bandage is coming up. Around the web space and around the thumb twice. So I'm going to leave sealing the end. So now I want to mold. So if you need a mold, of course, if it's a right hand injury, you're going to mold with the right hand. If it's a left hand injury, you're going to mold with the left hand. If you have a left hand and you try and mold it with the right hand, it's very, very difficult. So although the video is actually going a little bit slower, this sequence again is actually shortened just for the purpose of the video. Again, then using the offcut of my slab then, just to make sure I can anchor the bandage down. Of course, then I get a little bit of wool. And again, cleaning off the plasters remaining on the limb. Again, reducing any abrasions or any marks inside the plaster, reducing any pressure areas. Again, reducing any litigation claims of any pressure areas. So make sure you move his fingers. I can make sure you do a fist. And that is your Bennett's back slab. So when we look at upper limb casting, I think another thing that can often get forgotten or missed is once you finish your plaster, once you've given your advice and you send somebody home, it's important you apply the appropriate sling as well. So when we look at the appropriate slings, there are 3 choices of slings. So this is the first one. The broad arm sling. The high arm sling. Yeah, so this is my favorite. Anytime I put an upper limb cast on, a below elbow, I'm always going to put everything into a high arm sling. Now, the reason I prefer to use the arm sling for anything else is that I'm starting that elevation process straight away. As soon as I get that cast on, I want to get it elevated. I want to get swelling down. Another option that you have is the broad arm sling. Of course, again, very versatile, does exactly what it says in the tin, but it doesn't elevate it. Often enough, if you've got someone with an injury that's got lots of swelling and is kept there, the chances are the swelling isn't going to go down with a broad arm sling. You need that arm up high and elevated. And then we have the option of the poly sling. So you can use the poly sling for certain below elbows if needed, and you can use it for above elbow back slabs as well. Now, there's a reason why I put these on, is that I don't want anybody to think that they can, it's acceptable to use collar and cuff. When you apply collar and cuff with the back slab actually takes 48 hours to dry. So of course, if you apply a back slab on, a collar and cuff for the back slab, ultimately that plaster is going to crease, going to create pressure areas, and again increases the chances of pressure areas. Does anybody have any questions?
Yes.
Jacqueline.
Hiya, Darren. Thank you. Can you hear me?
Yes, perfectly fine. Thank you.
You know, on the Bennett's back slab,
Yes.
in total, how many layers and how did you distribute the layers? So the first layers you put on with the holes with the thumb, how many layers was that, please?
So the first roll, that's 8 layers.
So that was 8. And what about the second layer?
And then with the thumb, then that's just my 5 layer of the 10 centimeter.
So you got 13 in total there.
So 13 in total. But sorry, Jay, go on.
Also, when you went around the thumb, that was completely circumferential around the thumb, wasn't it? So that wasn't technically a back slab around the thumb. That was completely circumferential. Is that correct?
No, it looks like it comes actually circumferential. So when you get it right and you cut it, you're actually cutting it to fit the size of the thumb. So when
Just
you
the
put it on,
side.
yeah, so when you put it on dry, you can sort of put it on the inside, and where the cut is, it comes around this part of the thumb, especially if you need a mold here, but then the back then would be open here. So we,
Okay.
again, accommodating that swelling, we want to make sure that we get the plaster on right as well. So I try and make sure that when I put these, so the Bennett cast I've showed you now is just putting it on, but I could have gone more in depth with regards to cutting it, adjusting it. But again, because you get a chance to mold it around the thumb, you can make sure you can cut it dry before you put it on, so you can measure it specifically for the thumb, so it will accommodate the swelling as well.
Thank you, Darren. That's lovely. Yeah.
Very welcome.
Could I ask you another question with regard to the Collies type cast?
Yes, of course you can.
One of the casts you did, when you cut the hole, you did the standard below elbow back slab for the one
That's right.
type Collies. I presume that had the ulnar styloid fracture. When I saw the other video then, was that without a styloid fracture? Because that seemed just to cover the radius and didn't go over the ulnar aspect of the limb.
So that's right. So what you can do is that the reason I say about the sizes of the plaster that I use is that I preferably like to use the 15 centimeter. But if you've got someone who's got a ulnar styloid fracture as well, and you want to protect the ulnar styloid, you can use the 20 centimeter slab, and then you can cut that down as well, and to make sure you've got coverage on the dorsal aspect of the radius, but covering around to protect the ulnar styloid as well.
Okay, so if it's just a distal radial fracture, not a true Collies,
Yeah.
you would just isolate for the radius, not the ulnar.
That's right. That's correct.
Okay.
And then
okay.
if there's an ulnar fracture, then I would come around.
You
and
would
cut
cover
the
it.
ulnar as well.
Okay.
Yeah. So I would then use the 20 centimeter for cutting down. You know yourself, if you've got a 10, 15 or 20 centimeter slab, people often feel that you have to use one or other. There is no in between.
You
but
cut
the
it.
reality is you can cut it all down. And that's the
Yeah.
thing, is about developing that people to say, you don't just have a 10,
Yeah.
15 and a
One
20.
size doesn't fit all. Yeah.
That's right. Yeah.
Thank you so much, Darren.
No,
Thank
you were
so
very
much.
welcome, Jackie. You were very welcome. Anybody else?
Darren, there's a question on chat from Michelle Lewis. Any rationale for no tubinette before wool? Thanks.
Right. Now, it's one of those things where when I did the British Casting Certificate, we were taught under no circumstances would you to use tubinette. Now, I would definitely not use tubinette under a Collies reduction. When you get a molding, you create crease in the tubinette. Again, we are trying to reduce pressure areas, so I would highly advise against using the tubinette for Collies reductions. With that said, best practice, I think, is to not use tubinette with new injuries.
Yeah.
Again, that said, working at Bristol Royal Infirmary, they always knew when I did the below elbow back slabs, because I was the only one who didn't use stockinette. Everybody else preferred to use stockinette with their below elbow back slabs. So they knew which ones I did. And of course, I have to agree with my colleagues. When I worked in the Bristol Royal Infirmary, I saw no concerns. I saw no complications. I saw no pressure areas. So for me, it's neither here nor there. But in my head, I'm imagining stockinette creasing up underneath it. So for me, I chose not to use the stockinette for that reason. Any other questions?
Laura, on a Collies, which way is preferred to plaster? And from Ashley, do you do teaching for accurate cutting and measuring for back slabs?
Well, the accurate, I mean, so right, let's start with Laura first. What did Laura say, sorry?
On a Collies, which way is preferred to plaster?
Which way would, so that's very difficult, because I can plaster either way. I mean, I've done the job long enough that I don't want to say I can do it with my eyes closed, because I need my eyes to do the job. But, you know, for me, left nor right doesn't really make a difference. And the thing is, I want to make sure that before we do the Collies reduction, I want to make sure I've got everything around me. I want to make sure that the doctor who's doing the Collies and the manipulation is aware that I'm going to put the slab on, but he is very well aware that I'm not going to get that slab on until he has completed his manipulation. The molding will come when the plaster goes on. So for me, it doesn't matter what side, as long as I make sure I've got my space. And as you saw with the video of me doing the reduction with the Collies with my knee, you actually see that I can work in any space. So I'm not really fussy what side I work on.
Sorry, Dad, I think it came across wrong. What I mean is, which way of plastering is preferred? Doing it as you did with the hole in the middle, or doing it the first way you've done?
Again, that depends on how you have to look at how significant the injury is. You have to look at the displacement and the angulation. If you think this is a nasty injury, it's going to need a really good mold to make sure you reduce any chances of the fracture slipping, then I prefer to use the hole with the thumb. However, if there isn't a great deal of reduction and you're just going to do a little bit of manipulation to get it into a decent position, then of course then you can do the one with the cut over the top. Oh, Laura gone? And there was another question as well, John, is that right?
Yeah, from Ashley. Do you do teaching for accurate cutting and measuring for back slabs?
Not really, no. I mean, the reality, I mean, I'd be more than happy that I would be more than happy to obviously demonstrate cutting of a plaster, but it's bog standard. I think I've mentioned it with every below elbow back slab I put on in the video. I ensure enough room to allow for flexion extension of the elbow and for allow for flexion extension of the metacarpal heads. So as long as your patient can do this and flex and extend the elbow, it doesn't necessarily need to be appropriate measurements with regards to length. Now the width of it, again, the width you have to assess yourself. As long as you can cover, if say as we mentioned earlier with the true college fracture with the ulnar styloid, as long as you can cover the radius and the ulnar styloid, then of course you have to use your own initiative, your own incentive. You have to get the right plaster, you have to cut it down. If you're worried about using the 15 centimeter and it's not big enough, grab the 20 centimeter and just cut it down. Is that all right? All right there, John?
Yeah, you're getting thumbs up.
Oh, lovely. Okay. So next one, I'm going to look at the above elbow back slab. So when we look at the above elbow back slab, the first thing we have to look at is the types of injuries that we're actually treating. And the reason I think it's important that we discuss it is that what we often see a lot of in the plaster room is that patient needs an above elbow back slab, patient needs a below elbow back slab, and I absolutely know nothing about the patient's clinical history. I know nothing about the injury, and of course, these are things I have to do. And of course, when they come on a plaster room, these should all be completed. Of course, by doing this, I can ascertain as to whether or not the cast prescribed is actually appropriate for the treatment, for the injury, sorry. So we look at fractured elbows. You can have distal humerus fractures. Myself and John treated a fantastic one last week in the Royal Glamorgan with a nasty supracondylar fracture, and we cast it just purely for comfort. Despite the fact that this patient was going to theatre almost imminently, I want to make sure if that's going to be just 10 minutes, I want to make sure that patient is comfortable for that 10 minutes. We can look at mid-shaft proximal radius and ulnar fractures. Of course, we wouldn't, again, this is dependent on where you work. I can appreciate that not all hospitals will plaster a radial head fracture, but there are still hospitals that do still plaster radial head fractures. And sometimes you can't even see a fracture on an x-ray. So if you can't see a fracture on an x-ray, but you can see an anterior and a posterior fat pad, then you can ascertain that there's something going on there. So you would cast that just as a precaution measure until it's been assessed. So when I mentioned the distal radius fractures, and we would plaster distal radial fractures within 2.5 centimeters of distal radius. Does anybody know of distal radial fractures where we would actually go into above elbow cast? Go on, Jackie. Oh, Jackie's on mute, I think.
We used to do a Smith's or a Barton's fracture above elbow.
That's it, and this is why. And so the reason we look at, so the Smiths is known as a reverse collies, so exactly the same as the collies, but in a different position. So if you had to put your patient who had and I've seen it already being done a few times, a reverse collies, and the manipulation has gone this way, and they've gone into a below elbow, what you've actually done is that you haven't actually immobilized those joints from moving. So what we look at is if you had to put your hand in palmar flexion and ulnar deviate it and put your elbow into your side and try and supinate and pronate it, you can't. So the supination and pronation, so the radial, so the palmar flexion and ulnar deviation prevents supination and pronation. That's with your collies. With the reverse collies, we go the below elbow, and it doesn't prevent supination and pronation. So of course, that's what we have to do. So the above elbow is all about preventing supination and pronation of the limb. So this is why we put them into above elbow back slabs. So I'm going to show you now the application of so I'm going to show two videos. The one is a application of a above elbow back slab for your typical, say for example, mid shaft radius fractures. And then I'm going to show you another plaster then of the Smith's Barton's roller slab above elbow cast. All right, everybody ready? So here we have everything I would use for an above elbow back slab. Now, what you will find is that there are different methods of applying an above elbow back slab, but this is one that I find really works well for me. And the reason it works well for me is because it's been tried and tested, and I've had no concerns or any issues with it. Touch wood. So I've got a slab of 15 centimeter plaster of Paris. I've got a length of 10 centimeter plaster of Paris. I got my offcut. I got my 15 centimeter wool, 10 centimeter wool, 7.5 centimeter wool, and an offcut of 7.5 centimeter wool with 3 bandages. Of course, I got my scissors, and of course, important to me again is providing the written advice once your cast has been applied. So I'm going to show you the video of this cast being applied. So you want to ensure the elbow is at 90 degrees. So I'll start off with a larger wool. So the 10 centimeter wool. And I'll come around, and just before I come around the anti-cubical fossa, I don't want any tourniquet. So I'm going to use a little wadding of pad just in the crease of the elbow there, just to prevent any tension or any tourniquet effect in the anti-cubical fossa. So the 7.5 centimeter wool is my wool of choice when it comes to below elbow. So this is why I tend to break off here and then use a smaller wool. I find that it's a lot easier to manage and handle. So again, looking at this, if we were applying the below elbow past the metacarpal edge to ensure I've got enough to fold back, and I want to come up just a little bit just to protect the ulnar styloid. It's also important to remember as well that while the model is pretty strong enough here and holding the plaster up, you will need someone to hold the elbow with an injury. So this is the tip that I like to use when it comes to applying your back slab. So you can still use your little anchors around the corners. But what I find happens is if I use this during treating someone with an actual injury, this anchor here actually makes it easier for me to apply the plaster when I need to apply the larger slab. Again, so making sure the wool is, the plaster is saturated. So you can see how quick that sticks to the back of the arm. So what you've got is, if you've got someone with an actual injury rather than a model, what I have found is that you can often spend time trying to stick your plaster on and it falls off. Then you try and stick it back up, then it falls off. And you find yourself in a position there, by the time you actually get it on, the plaster's dried. So what you will find is that if the patient is holding their arm up, like my model is, you'll often find that this is going to start getting heavy very, very quickly. So what I try and do is exactly the same as if I was doing a collar reduction. I want to get one bandage on, and then I want to take that weight and I want to support that patient's limb. So I'm going to rest the elbow into the palm of my hand. Again, I don't want any fingerprints, so it's in the palm, and I'll use my right hand then just to make sure then that the wrist doesn't go into radial under deviation, or it doesn't supinate or pronate. So what I would use is just tap my thumb on it, just make sure it's setting fine, and then I'll ask a patient to raise it back up. Then obviously, if there was someone there with me, I'd have someone to give me a hand then just to hold the limb while I complete the plaster. And then the same apply then. So with the second bandage, this is the one that I use, what I call the aesthetic bandage. This is the one that makes the edges look half decent and clean and tidy. Once I've got this on, I'm then going to continue up the limb, because what I want to make sure, again, is making sure that when I put my ankle on to support this and stop it from unraveling, I want to make sure that the slab of plaster I use is actually away from the fracture site. And by this point, the plaster should have started to set, so it gives the ability for the patient to drop the limb down on a soft surface. I cut off my excess bandage, and then I want to anchor that down. So when we anchor the bandage down, we never go over the open part of the plaster. We don't want to complete the cast. We want to ensure that this plaster can accommodate the swelling. If we put this over the open part of the plaster, of course, then you're effectively completing the cast. So of course, we'll check the range of movement, make sure the patient can move all their fingers, make sure there's no neurovascular deficit. Of course, you could check a cap refill. They're a good assessment to do before you discharge your patient, just to make sure there's no concerns or complications. And that is how I apply a above elbow back slab. Now, what I like to do a lot of is if you've got someone who's got a simple injury that you can apply this above elbow back slab with ease, then of course we can get it up, slab on the back, and then you can use your supported anchors then over the corner then just to ensure that you protect it. But often enough, these are just showing you ways of, if you've got someone who's got a significant injury, or there's a reduction, or there's an injury where you feel that plaster needs to get on quick, this is definitely a great one to use, because those anchors actually stop the plaster from falling off. Again, these are tips that I can provide, but I'm sure that if you've got casting standards within a department and the area that you work, then of course you'd have to confirm it with your leads there to see whether or not it's an actual method that you could actually use. So what I'm going to look at next is I'm going to look at a above elbow back slab for the Smith-Barton's fracture. So again, I'm going to show you a little picture of all the equipment that I use. So again, the same amount of wool as I would use for my previous above elbow. So I got my 10 centimeter wool, my 7.5 centimeter wool, my offcut and my 7.5 centimeter wool. I got two 7.5 centimeter bandages. I got a length of 10 centimeter slab. only 5 layers, and I got my 8 layers in of my 15 centimeters in for the Barton's cast. So I'm going to show you a video of the cast being applied. So of course, what you will often find is this has already been manipulated. So if it's been manipulated, you'll often find that the doctor will not be holding the wrist in this position. So locking in the layer of wool and then coming back around. Again, a piece of wool for the anti-cubical fossa. I don't want to create any tourniquet effects there. And then I want to complete then the rest of the lower at the upper limb then with the 7.5 centimeter wool. So again, cutting the wool rather than poking a hole in it and feeding the thumb through the hole, and then breaking off then over the ulnar styloid. So again, often enough with these types of injuries, you want your plaster on quick because it's probably been manipulated and it probably needs molding as well. So this is just a quick way of just showing you how you can make sure that if you need to get your plaster on quick by using this anchor and make sure that it's wet, it means that when you put your main part on, it's got something to stick to without it falling off. So you spend less time potting with your plaster. I started on the volar side, and you see then I've worked my way around and up around the back of the arm then. And again, because speed is the key with this one, again, I won't worry about folding the wool over. I want to quickly get the bandage on. I want the manipulation to be done. You want the molding set. And of course, then you want to make sure the patient's comfortable without the risk of the plaster moving before we continue to make the plaster look aesthetically pretty. So again, the importance of ensuring that you've got that wool coverage over the ends of your plaster, again, will reduce your pressure areas rubbing. Unfortunately, despite doing college reductions or doing these types of plasters, they are at risk of developing pressure areas. So of course, where I'm molding it here now, this is effectively where the doctor would be molding it. So the doctor has done the traction and manipulated the injury. This is where he will be molding the plaster. So of course, if you end up with these patients with pressure areas or rubbing, despite the fact that it could be a great reduction, unfortunately, if there are pressure areas present, of course, tissue viability nurses get involved, the indexes get completed, and often enough, then the plaster has to be removed for an appropriate assessment to be completed as well. So this is why it's important that we try and ensure that we protect the edge of the plasters with the wool, so we can do what we can to prevent pressure areas from happening. So gentle tension, and then that's it then. So we completed. So we would finish off the year, again, away from the injury. And of course then, the leftover wool. So I want to make sure that every time you do these plasters, that again, there's no neurovascular deficit, that you make sure they got a good range of movement. Of course, you'll have other assessments like a cap refill, but for now, this is just a case of showing how to get the casts on. And that is your above elbow for the Barton's Smith type fractures. So what we're going to look at next is the below elbow back, the Baloney back slab. So when we apply the Baloney back slab on, it tends to be for distal third tip and fib fractures. Again, you can apply the plaster for pre-op or dislocations. Again, doesn't matter if you put a Baloney back slab on for pre-op or dislocations. I still can't stress the importance of ensuring that you get that foot in a neutral plantigrade position with no inversion and no eversion. You can look at certain foot fractures can have a back slab on. So I know there's some places that are still using Baloney back slabs for calcaneal fractures, and some prefer to use woolen crepe. Use your base, your metatarsal fractures. So you can look at your typical Liz Frank fractures, and of course with Jones fractures. And of course, the issue with Liz Franks and Jones fractures is they really do have poor healing. With Liz Franks, they will often require surgical intervention. There are still some hospitals that still like to put Achilles tendon injuries into Baloney back slabs. So of course, but then the plaster then goes on the dorsal aspect rather than the back. And of course, then we're looking at the trimalleolar fracture. So you can look at the bi or the trimalleolar fracture, and these are unstable, again, requiring open reduction and internal fixation, so also known as your ORIF. Now, I want to concentrate on the ORIF, the bimalleolar and trimalleolar in a minute. So the bimalleolar fracture is actually quite rare. So if you see someone and on the AP X-ray, they've got what looks like a bimalleolar fracture, chances are they can have a posterior malleolar fracture as well. Often enough, these patients can come in with some pain, and sometimes they might not have any pain. But it's important that if you look at an X-ray and someone does have a bi or a trimalleolar fracture, it is unstable, and they cannot be transferred to the plaster room in a wheelchair. They cannot be transferred anywhere. They need to be put on a trolley with adequate pain relief, and the plaster needs to be applied. So I'm going to show you a photo. And the reason I want to show you this photo is this patient was having a plaster applied. He had a bit of a drink. And as far as he's concerned, he twisted it. He hasn't really broken it. But unfortunately, that wasn't the case for him. So all patient identifiable information, there's nothing on there, okay? So that should come up in a second. There we go. So you can see the injury here. I mean, we can't see the posterior malleolus, but the chances are that's gone anyway. This is an unstable injury, and this patient had had a drink. So of course, this patient had a drink, wasn't really fully aware of the extent of his injury. This is why it's important that whenever we apply back slabs, that we are fully understanding what it is that we are plastering. Try and make that conscious effort of assessing the X-ray to see what it is that you're plastering. Because if you don't, this can happen. So of course, despite the fact that this patient was going to surgery to have an open reduction internal fixation done, this is not appropriate. This actually put the patient more at risk. So if you can see that somebody has a fracture either side and is unstable, please get another pair of hands to help you. We don't want this happening again. So then we look at the below elbow back slab, sorry, the Baloney back slab. So again, I've got my 20 centimeter slab this time, and you can see the edges are well rounded. I've got my 10 centimeter slab then to act as the anchor. I've got my one slab, my two 10 centimeter walls, and my 3 bandages. Often enough, I'll only ever really need to use 2 bandages, but I always have a spare there as a backup. So what I'm going to do now is I'm going to show you the video of me applying the Baloney back slab on. So I've paused the video for a second just to explain to you what I've done. Before I applied the cast, we can see that the cap refill would have been checked if it weren't for the fact my model had nail varnish on. There's a good pedal pulse present, but what you saw me checking there was for bony prominences. I want to make sure that every bony prominence of the foot and the ankle can be protected as well as the knee. So when we look at the bony prominences, we look at your median lateral malleolus. You can have bunions on the 1st and 5th metatarsal heads. You can have an accessory navicular. Your base of your 5th metatarsal can also be prominent as well as your fibular head. But one of the most important things that people tend to forget is what they call an Argland's deformity. The Argland's deformity is a deformity at the back of the heel that tend to get missed. And of course, with the Argland's deformity, if it gets irritated, it can create what they call a bursitis. And of course, that bursitis can create an inflammatory response. So of course, we need to make sure that we do everything we can to protect it. So I check the back of the heel, the foot, the ankle, and the fibular head. So here I'm going to do what I call the figure of 8. I come up and around, covering the bottom and the top of the heel, and then coming in a bit closer to the heel here to protect the heel again. The video seems to slow down quite a bit, sorry. So again, going 50-50 with the layers. And I like to double just at the end then, just to ensure that when I've got double layer wool protecting the end of the plaster. So again, this is our ideal tip. Again, if you're doing an ankle reduction and you want to get the plaster on quick and somebody's holding the foot, this works, because by the time they got their hands on the heel and they're holding the foot, this doesn't actually interfere with them holding the foot. And then my 20 centimeter, 8 layers. So I make sure this comes up onto the metatarsal heads. And I want to use my chest then just to hold that plaster in place. And when you see these anchors, you can often find that you can be fighting to get this part of your plaster on. But by putting these anchors on, it actually supports it. So it gives it something to almost anchor onto as you apply your above knee back slab. So when we apply the Baloney back slab, it's important that the patient rests. If the patient can rest the leg rather than extend the knee, you are more likely to get an appropriate plantar grade, so the foot and ankle is at 90 degrees. If the patient is extended, the chances are you're not going to get it at 90 degrees. So the patient has to be relaxed and comfortable. So if the patient comes into the plaster room with 5 toes, it's also a good idea to send them home with 5 toes. So again, then once that's, so I always, my first bandage always starts, sorry, my second bandage always starts at the foot and then works my way up. So at least that I can guarantee that when I secure my bandage, it's been secured at the far end, so it's not going to obscure any fracture when they have any postcast x-rays. Of course, I'm securing it at the back. What I don't want to do is secure it on the inside, because again, despite you trying to massage it and make sure that I laminate it all in one decent piece, so there's no sharp edges, there's no guarantee that it doesn't create any sharp edges. So I always try and secure it at the back of the leg. So what I'm trying to do is just to make sure I maintain the position of that foot. I don't want it to go, I don't want any inversion. I don't want any, so I don't want inversion or eversion. And I want to make sure I keep that foot in plantar grade position as well. And again, the same applies here. Again, ensuring that you clean off any plaster and you clean up plaster from both ends. Another thing to be mindful of is wounds inside the plaster, especially when it comes to lower limb. If you end up with a wound inside the plaster, sorry, and it bleeds inside the cast, that blood will go hard. And of course, that hard inside the plaster will be an absolute nightmare for patients. And I have actually seen patients developing pressure areas from dry blood inside the cast. And then that then is my Baloney back slab. So I'm just going to show you some photos of the plaster on. So just wait for the picture to come up. So whenever you put a Baloney back slab on, you always want to make sure that the second toe is in line with the knee. That way you can almost guarantee that that's going to be the perfect position. And you want to make sure the foot is at 90 degrees. And that's your back slab applied. Does anybody have any questions about the Baloney back slab? All fine? Okay. So a quick one just about the Vte assessments. Now, Vte assessments are absolutely massive when it comes to applying low limb casting. Now, I have to give credit to one trust in particular, especially my old trust, which is the Nine and Bevan University Health Board. The reason I have to give them praise is that not only are they sticklers for a Vte assessment, but as far as I'm concerned, the assessment gets done with every single lower limb cast that is prescribed. So the Vte assessment, is everybody aware that the Vte assessment is in the NICE guidelines? So I can't hear anybody at the moment.
Yes,
Yes,
Dan.
Darren.
Yeah.
Oh, sorry. Is everybody aware that there's a Vte assessment on the NICE guidelines?
Yes.
Yeah. So with the NICE guidelines, so document NG89, and it states, and I quote, a Vte assessment must be completed when any clinical decision is taken to manage an affected limb in a way that will prevent normal weight bearing status or use of that limb or both. So this isn't just about applying a Baloney back slab. The same would apply with your boots. You put someone in a boot, a Vte assessment has to be completed. So the British Medical Journal reported that within the last decade, a VTE has resulted in more deaths, wait for it, than prostate cancer, breast cancer, road traffic collisions, and AIDS combined at a total cost of £640 million. So it's a huge amount of deaths, isn't it, when you think about how much that's cost, how many people has passed away as a result of it. So of course, we look at the things that we assess. You know, we look at the age. Anybody over the age of 18 that you apply in a cast must have that VTE assessment before you cast them. So of course, when we look at over the age of 18, anybody over the age of 16, as long as there are no contraindications, then they should be looking at starting some sort of prophylaxis treatment. It looks at things like your BMI. So the BMI over 30, you'd look at a prophylaxis treatment, or again, as long as there are no contraindications. But then the NHS does have a site that allows you to calculate the BMI. But what that site allows you to do is calculate the BMI based on age, weight, ethnicity, and it also incorporates the amount of exercise. But if you want to use that calculator to calculate somebody's BMI, what you will find is that if it's asking someone's level of exercise, but pre-plaster, they were doing 30 minutes a day, you can't incorporate 30 minutes a day because effectively you're taking all that away from the patient. So of course, it's important that the VT assessments gets completed before the cast is applied. So just to shut it down really quick, again, just please, if anybody prescribes a cast, please ensure that you get the VT assessment completed. And finally, has anybody heard of patients being given or recommended aspirin as a prophylaxis treatment for DVTs, for casting?
Yes.
No. So there are still lots of hospitals that would say to your patient, take aspirin. However, I can say now that the aspirin should never be recommended, as aspirin has never been pharmaceutically approved in prophylaxis treatment for DVTs. So if your patient needs a DVT, is at risk of DVT, and you've done the VT assessment, of course, this is something that you might have to incorporate the use of your local pharmacist. So when I say local pharmacist, sorry, your on-site pharmacist within the trust, as well as your consultant or clinical director. So just to quickly shut it down, I'm going to show you a couple of photos, and I'm going to ask you some questions about the photos. So hopefully this photo will come up. Ah, there it is. Can anybody tell me what's the matter with this photo?
Toe ring.
The ring. And there's something else as well.
Something on the end of that.
So what I'm going to say is, yes, the rings. So when you look at the rings, this patient's had a college reduction done. So before this college reduction done, they were seen at triage, they were seen by the practitioner, they were sent for x-ray. The cast was then applied, and then they were sent for another x-ray. That's 5 opportunities where these rings could have been taken off. And if you look at the thumb is practically all incorporated into the cast. See again, so we need to ensure that the thumb isn't incorporated in the cast, especially with the ring. So I'm going to show you another x-ray. This again is a trimalleolar fracture, but all I'm showing you is the lateral view where you can see the posterior malleolus is gone. The posterior malleolus is gone, which means that the huge proportion of that articulating surface is gone as well. So it's important that people are aware that if they see injuries like this, it's unstable. Because if you don't understand what it is you're casting, then you apply your plaster, this can happen.
Oh.
So again, these are the things I'm trying to educate people on. These are the things I want to show people that are important to us. And another thing that's important to me is patient safety. And I don't know whether or not you'll notice I also mentioned a lot with regards to pressure areas. Make sure the patient gets that ability to be able to move their limbs. I want to make sure that when the patient goes home that we can psychologically, mentally prepare our patients for the discharge home. You know, you need to be mindful that we have to remind these patients that you have to clamber your stairs. You've got to get up and down the stairs to the toilet. But then we have what I call that clever dumb balance. And that clever dumb balance is, oh, by the way, I know you've got a ton of stairs to clamber before you go to the toilet, but we also want you to maintain your hydration. We want you to drink plenty. We need to make sure you eat healthy. So we'll have to look at incorporating family care and external services like the Red Cross or the Salvation Army. So it's just, as you know, our care doesn't just end within the classroom, it stems beyond the patient's front doors as well. I hope you've enjoyed tonight's meeting. Before I shut it down, I do want to ask, does anybody have any further questions?
There's one question on the chat. How long
Yes.
it's got off my screen. Hang on. How long does it take for plaster to dry, both initially but also more permanently?
So that depends on the temperature of the water. But ultimately, the plaster of Paris will take up to 48 hours to dry. The plaster can set relatively quickly, depending on the temperature of the water. But ultimately, again, like I said, it takes 48 hours for that plaster to dry. So it doesn't matter how quick that plaster sets in your hand, you still got 48 hours for that plaster to dry. These bits of plaster that I cut here to show you earlier, I had to cut them 3 days ago. So make sure that they dried for me to do the demonstration today for you. Are there any more questions? No? So what I'm going to do is I'm about to put a QR code on the screen. The QR code is for feedback, and I really appreciate your feedback if you don't mind filling it in. So if you've got mobile phones, is this how it's normally done? Is it put on the screen and then scanned that way?
Yeah, stick it on the screen, but we can also email out everyone the link as well.
Yeah, so I'm going to quickly put it onto the screen for people to see it. Are you all right to scan it? I'll leave it there for 30 seconds. And then I've got one last photo, one more announcement that I have to make. Is that all right? Lovely, right. That should come up in a second. Lovely. So if you scan the QR code, and I think there's some instructions you have to follow then to give some feedback, I'd really appreciate your feedback.
Yeah, it goes to a feedback form. Once you've completed that, it's not a very long form. Once you've completed, it will email you a certificate for your portfolio as well. Melanie was asking about rewatching this. This has been recorded. It'll go onto the FEN website. It'll probably take about a week to make sure that the recording
It goes
is.
into the members area of the website, John. Yeah. So if you're a member of FEN, then yes, you will be able to rewatch it.
And I will be more than happy to provide the videos as well for you to apply onto your, you've got a YouTube page, is that correct?
Yeah, we do.
And I'll forward the videos for you to apply to your YouTube page as well. It's not a problem at all.
Thank you, Darren.
That's okay. Everybody done with the QR code?
Thank you.
You're very welcome. So finally, the very last thing I have to do is I have to thank you all very much for being a part of this night, and more importantly, allow me to be a part of this. I know we're not, you know, that I'm passionate about plastering, and it's not just the plastering, but it's about the outcomes of patients as well. Now, this isn't possible for me if it wasn't for somebody that inspired me many, many years ago, and I know she's probably going to have me undrawn and quoted. So I feel I owe a great deal of gratitude to a certain person who inspired me. So I hope you don't mind if I just share this little photo. This lovely. I watched this lady plaster. It must be about 17 years ago. And I was absolutely in awe of how amazing she was. And she inspired me to take this path into plastering. And I will never forget what she's done for me. So thank you, Jackie. Does anybody want a screenshot of that as well?
No, I beg you, no.
So yeah, thank you all very much for allowing me to be a part of this and inviting me.
Thank you so much, Darren. That was excellent.
Lovely. Thank you very much, John.
Thank you, Darren.
No, you're very welcome. Thank you so much. Thank you very much.
Sorry, can I just say, Darren, as president of the Faculty of Emergency Nursing, how much I've enjoyed your presentation tonight.
Thank you.
It's been absolutely fabulous. And it took me back to when I started plastering. And I think it must have been in 1977, because I did an orthopedic course before I did my general nursing. Yeah. And it's nice to see that the principles are still applied today. I must admit, I did do the use the tubinette underneath the plasters there, or the stockinette it was, not tubinette.
Yeah.
And the only other one suggestion, I got a couple of other suggestions. One is there's also a tucker sling, if you've ever come across it, which is not so much for plaster, but if they're coming out of plaster, then it's again a high arm sling that you can use out of stockinette, that you cut a long, long piece, and at where the elbow would be, you'd cut halfway through, and it seems to be far easier for the elderly to manage because you tie it in the knot in the middle of the back.
When I worked in Bristol, they showed some absolutely fantastic things with the different types of slings. But yeah, I think, you know, it's more of a case of it's worked for me. But yeah, I never really had a chance to really study it.
And those are the common ones. Those, and they were well put on. I have to.
I can imagine.
And the other thing is, when it comes to emergency care, I know orthopedics might be a bit different, but the VTE starts at 16 is what the Royal College of Emergency Medicine guidelines are, rather than doing the VTE protocol at 18. So it's slightly different, I think, as a very.
Yeah, I mean, again, that comes down to sort of different hospitals and different trusts, how they do it. I know ComTAF have got a thrombosis committee, and they use, again, a completely different Vte assessment. Again, there's long-winded, there's lots of paperwork that are involved in it. And then when I looked at the 9 and Bevan, it's just a one sheet, and it's straight to the point, and it was absolutely fantastic. And I felt that
what we introduced in Nice was we had a really small sticker that you went through the initial assessment, and only then did you go on to a second assessment should you need it. But it was an initial small sticker you put on the CAS card that worked really, really, really quickly and easily. So, and it picked up on all the components there. So I'm sure they'd be willing to share it if anybody wants it as well.
Absolutely.
Likewise, I'm sure that Claire McCarthy, consultant nurse, would be happy to share it from Iron Bevan.
Lovely.
Yeah, but brilliant. And thank you ever so much. We really
No,
do
pleasure's all
appreciate it.
mine. I think what I'd like to do later on, if that's okay, is maybe host another seminar, a webinar later on down the line, and look at things like Thomas splinting, Prometheus
Oh,
splinting,
yeah.
and above knee casting.
Yeah, that would be
That'd be great.
absolutely fabulous.
Yeah.
And I
Lovely.
loved the videos, and they didn't appear slow. I think they were going at the speed that people needed to see them at. So they
Yeah,
were
and
really
that worked well for me because I was hoping they go a little bit slower, so it gives me the chance to explain what was happening. But yeah, thank you ever so much. Anyway, thank you all for inviting me. It's been great. Thank
Oh,
you.
it was fab. Thank you.
Not a problem. Thank you very much.
Thank you.
Do I leave now or do I get kicked off?
I'm gonna kick you off.
Jackie, thank you ever so much.